some history of tibial trauma for about 8 months back before presenting to us. Though there was no history of any fever or any other joint involvement in the body, and no treatment was taken or any intra-articular injections were given for that. In the past history, when I took, he gave me the history of about 2 years back. We had a stroke incidence for which he was treated, but now there was no residual neurological or neuromuscular dysfunction. Along with that, we had no pre-existing comorbidities, no significant personal or family history, and no history of any drug or long-term medication for any reason. When I did my examinations, everything else was fine except for the palpable loose bodies along with the swelling, and there was varus deformity bilaterally, whereas there was 15-degree flexion deformity on the left side. The range of motion was restricted up to 100 degree and was painful. There was significant laxity both in anterior and posterior direction, along with the lateral collateral ligament laxity. There was no limb-limb discrepancy. There was a huge wasting of quadriceps and no neuromuscular involvement, and the systemic examination was unremarkable. Through radiological evaluation, I could see that the left side was more there was advanced tricompartmental osteoarthritis on both the sides, but left side was more marked with multiple osteophytes and subluxation of left knee, along with the marked bone loss on the posterior middle aspect, with multiple loose bodies of variable sizes in the left side of the knee. So, having gone further with the routine investigations like CBC, ESR, CRP, rheumatoid factor, NTCCP, ANA, serum uric acid, and other routine investigations were all normal. So, considering my examination, history, and radiological evaluation, as it is a monoarticular joint involvement without any history of infection and other reasons, in the settings of osteoarthritis, a history of tibial trauma, I suspected it to be a neglected post-traumatic synovial chondromatosis with advanced secondary osteoarthritis on the left side. I further went on to get the MRI done to confirm my diagnosis and other possibilities of infection and other to rule out other pathologies. The MRI was suggestive of synovial chondromatosis with degenerative arthritis, which is a very rare disease, only in 1 in 1,000 people. 1 in 100,000 people. So it's a monoarticular disease arising because of the metaplasia and proliferation of synovium and producing lot of nodular swellings which get detached from the synovium itself and get nourished by the synovial fluid, and they grow in size. They may be of variable sizes ranging from small to pinpoint to a marble size, and they also go under ossification and calcification. So the diagnosis was a bit obvious through MRI and radiological diagnosis. So how do I approach? What do I have options with this? So the options were very limited. Arthroscopic debridement and removal of loose bodies, high tibial osteotomy along with the debridement, or should I go for a total synovectomy and total knee replacement? Considering the limitations of the procedures and the technique, arthroscopic removal was probably not possible, not demanded at this point of time, along with the high tibial osteotomy. So I went through the extensive literature search, and I found this paper of Matthew in Journal of Arthroplasty in 2017. Here also they have showed high rates of local recurrence and complications following total knee replacement in settings of synovial chondromatosis. They have shown that the 5-year survival rate is, disease-free survival is 73%. Although they concluded that the total knee arthroplasty in this setting is a very good option to get range of motion and to make patient pain-free and comfortable and assist him in the activities of daily living. So I opted to go for open synovectomy, debridement of glute bodies along with a total knee arthroplasty, as the joint was not amenable to arthroscopy or STO-like procedures. Through a standard medial parapatellar approach, I performed the surgery and the synovectomy and debridement was done. The numerous corpora libra removed perioperatively were sent for histopathology, which further and went on to do further with a standard cemented total knee replacement, and I did not encounter any intraoperative complications. Synovial biopsy further confirmed the synovial chondromatosis. And patient was put onto the standard operative rehabilitation protocol, and he regained satisfactory range of movement and function. There was no residual pain, and he was able to carry out his activities of daily living with the ease. And this is the follow-up X-ray of day before yesterday, when he was visiting for some other reasons. And this is the video of day before yesterday when he was visiting. Before I play this video, I would like to add on to some information. Day before yesterday when he visited, I just called him to see, and he was almost bedridden for last 3 months because of his severe backache. But then too, I asked him to, if he could walk few steps. He has pain on both the sides. Right side pain is more, but the left side, he also has some pain, residual pain on the left side. Although I can see his knees are bent, he has some flexion deformity in both the sides, quadriceps. He is not doing any exercises right now. He was bedridden almost for 3 months. Now, how do we go about with this patient? I would like to know from the... Since this is my first experience with such kind of patients.
Dr. Sunil, you have presented very nicely, but the problem is that you have not evaluated the hip and spine, because this gait was pre-operative gait. How was it? Pre-operative gait of the patient. Was hip was normal? Because seeing this gait pattern, there is a hip is also involved.
So how many years follow-up you have? How many years follow-up?
Around
3 years. And when is the last knee X-ray you took? Knee X-ray is fine. But he's having back pain and radical. Yeah, probably that is probably a new pathology he's developed. They evaluate you for. So this is not related to the knee arthroplasty. I think knee arthroplasty is doing well. Probably developed a new pathology now. Spine. It is not related to this. Usually synovial chondromatosis, if you do a good radical synoviectomy and joint replacement, results are good. So this is a new pathology not related to arthroplasty.
Can I
just a quick question. How painful was the knee pre-operatively? Because was there an element of a neuropathic joint that we should rule out? That's number one. Number two, if his gait pattern was similarly broad-based pre-operatively, we probably should have done a proper neurological examination, including the back, whether there's a cerebellar cause for this, ataxic type of gait. And also probably now, I think it is worthwhile to begin with a good proper clinical motor examination and then go ahead to look at the back and a neurological examination. If he's having bilateral knee issues and stiffness, because he looks like he's in some sort of definitely there's an element of nerve root irritation and spasm is what we can see.
Yes, sir. I had the possibility, as you said, neurological weakness, but there was no residual weakness or any sort of neurological problem just before the surgery.
Okay.
Though he had a history of 2 years back stroke, like left-sided hemiparesis also, but it recovered completely.
So right now he's having both bilateral volumes, probably he needs a detailed evaluation now.
No, other thing I agree with Dr. Anil, if you're evaluating a patient with gross instability, with a lot of newborn formation, you have to rule out the neuropathic arthritis. The evaluation should include joint sense and vibration sense has to be assessed. MRI and nerve conduction study has to be done. If you had done that beforehand, probably you would have detected some spinal pathology also. So even in this case, even now it can be a neuropathic arthritis. You cannot rule out, unless you do a spine MRI and nerve conduction study, you cannot rule out the neuropathic arthritis.
See, I would more or less agree with your approach that it was too bad a joint and asking for knee replacement, more or less. But there is a word of caution. Word of caution is he's too young, number one. He's from a rural background, number two. And all these patients on day one, they are amazing. They do so well. It's a magic operation. But what happens to this patient 10 years down the line, particularly when he's in a rural environment, has to be also looked at. Can you be conservative? Which means, what was the main symptom of this patient? If the main symptom was pain, I said there is no option but to do knee replacement. But very often the pain tolerance is huge, and generally osteochondromatosis, they are not very painful. They are just okay. So was there a possibility of doing an open debridement and a osteotomy to get the alignment right, to give this young man another 10 years, considering his background? If he is a city-bound patient, I would have no second thought but do a TKR. But a rural patient, when you do a TKR, you kind of give a Mercedes to a juggy developer, I always say. He has no way to go because he has to sit on the floor. And the revision of that knee is going to be disaster for him. So you are pushing actually into a disastrous route. So if it is avoidable in a rural population, in a young patient, think of options. Even in a bad knee like that, if you do a good corrective osteotomy, good joint debridement, I am sure it will last for 10 years. And then you can always do TKR because then there is no other option. So considering age and the background of the patient, sometimes we have to scratch our brain and say whether we can still go on with non-TKR options. That's my only, I would do a TKR in this patient for sure. But if it is in city, 100% TKR, no doubt. Of course, we rule out neurological problem, etc. That's a fair comment. But just a warning, because a lot of people are from very rural background, and TKR is a very juicy operation on day one. You should always think what happens 10 years down the line for this particular patient. Thank you.
Okay, I think we'll go for the next, and I would request, especially the presenters, to stick to the time. The time is flashing right over across the podium, because both these speakers overshot it by around more than 2.5 minutes.
So you get 10 minutes more.
So Dr. Madhav Luthra, again, young surgeon, and he's doing a really good job. I can vouch for it. He operates many of my patients also at times. He's a good vestibular